Sim, vamos lá.
Okay. Hello, everyone. Thanks to the organizers for asking me to speak. I'm Camille Kotton, and I am the Clinical Director of Transplanted Immunocompromised Host Infectious Disease at Massachusetts General Hospital in Boston. It's really an honor to be with all of you today, and I will be talking about safe travel after solid organ transplant, including vaccines and infection prevention. This is one of my favorite topics to talk about. We work so hard to get people through organ transplant that it's really a joy when they can travel after transplant. I have a few disclosures. I do some consulting work with vaccines, and then I give a lot of opinions about various vaccines. I will also be discussing some off-label use. Hopefully none of that impacts my talk. So I'll be giving a brief overview of diseases during travel, discuss risk and how to mitigate risk of infections when traveling. And then I will talk about vaccines, both live and non-live, as well as some non-vaccine travel preparation and some resources and tools. This talk will not include significant mention of coronavirus, so you do have a little bit of a vacation from coronavirus during this talk, thank goodness, right? I will say that overall, though, obviously people are not doing much travel at this time, so hopefully this talk is aspirational and that soon the coronavirus pandemic will be done and we can go back to life as normal, which included a lot of travel, which is not happening right now. So with respect to travel-related infections, you know, it's all about location, 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 kind of like we say with real estate. And there are some travel-related infections of special concern, and I'll just highlight these. Whenever people travel, we have concerns about things like tuberculosis, and that's worth considering, especially if people have just returned. Similarly, we worry about malaria through much of the world where people may travel. And worth considering things like prophylaxis. There are a whole host of tropical invasive fungal diseases that can occur, and especially in immunocompromised travelers, so these are worth contemplating with recent travel. There's also various kinds of leishmania that probably in Brazil you're much more familiar with than I am, but think about recent travel. And ditto here as well for leishmania. So there's also things like what we used to call Penicillium marneffii that comes out of Asia, worth thinking about, especially in patients who might present with a fungal pneumonia after recent travel, and things like melioidosis as well. Darwin in northern Australia is one of the more endemic regions, as well as the Indian subcontinent. So worth thinking about these things, especially at times when you might not otherwise be expecting it. So what can we do to mitigate the risk of travel-related disease? Well, I'll talk about timing, various aspects of duration and type of travel, the depth of immunosuppression, and then access to healthcare. So the timing of travel can really have a significant impact. So let's just run by some what have been some good or manageable decisions. Things like a liver transplant, who's actually one of the lost boys of Sudan, who was stable for 3 years, now going to Uganda for 6 months, visiting friends and relatives. He actually was going to get blood work done every month, email it to me. He had enough medications, and he had a plan to return to the United States if he became ill in country. So that's a pretty good plan. Ditto, a kidney transplant patient who's now 2 years out, stable kidney function, low dose immunosuppression, wanted to work in Iraq for 6 months, and he had a good plan if he became ill in country. So that was great. On the flip side, how about returning home to Morocco after kidney transplant? She's already had an episode of rejection. She's actually dependent on coming to Boston for monthly belatacept infusions, and she's planning on flying back every month. If she gets sick in Morocco, she does not have any capacity for healthcare available there or in France. So that sounds pretty tenuous and at risk for not being able to get her belatacept, especially if there's something like a worldwide pandemic, right? And then another case I saw was a professor at a Boston institution who was also working in rustic South America, who has a new diagnosis of an ANCA-positive vasculitis, high doses of prednisone and rituximab are being used. And her clinical course was actively evolving, wanted to return back to rustic South America, far away from healthcare for a prolonged trip. So that timing, these seemed like bad ideas, right? So what about timing? So in the Center for Disease Control, which is our a yellow book, which is our travel medicine book for the United States, we do say that we, in the chapter I wrote with David Friedman, we do say that we don't recommend travel for the first year after transplant whenever possible. They're more likely to experience rejection, surgical complications, and they may not be so stable. So whenever possible, we do recommend not traveling during that first vulnerable year after organ transplant. We also recommend thinking about the net state of immunosuppression when they travel, and optimally they would be on lower immunosuppression at that point. Hopefully they would have comorbidities in check, better control of diabetes, lower doses of exogenous immunosuppression, and they would have stable graft function, and overall it would be a good time to pick for them to travel. Also important to talk to them about things like healthcare, what options would be available wherever they're traveling, what about transplant care, how can they contact the home team. Really important to bring extra medications and think about contacting the embassy if they're truly sick in country. And then also think about the concept of medical evacuation insurance in case they need to come home. For all of this in general, it's really important to think about having enough time to vaccinate them, educate them, and have good plans in place in case of illness, etc. So let's talk about vaccines, safety, immunogenicity, and recommendations. So this is the US schema for regular adults, and it's divided up by age, and you can see the various vaccines on the left and then the various age groups. And although I find this helpful when practicing internal medicine or regular infectious disease, I actually really liked what we call Table 2. And the second column over includes immunocompromised hosts. And I find this clinically quite useful. Further along, you also have asplenia, or people who don't have a spleen anymore, end-stage renal disease or on dialysis, heart and lung disease in the middle there, chronic liver disease. So these guidelines are really, I think, quite helpful. And you can see that many vaccines, as shown in yellow, are recommended, or if there's special risk, in purple. And then things that are not recommended are in red, like where can you do harm? And I think as doctors and clinicians, we always want to avoid doing harm. So things that are not recommended for immunocompromised patients like organ transplant recipients would be live influenza, MMR, chickenpox vaccine, or live zoster vaccine, which is coming off the market anyway. So there are a few things that we should really avoid, but otherwise there are a lot of recommended vaccines of the regular things. I will say, what about vaccination in the immunocompromised host? There's honestly very little data on travel-related vaccines in this population. Titers we would generally expect to be lower. We don't have good studies of protection. Immunity may wane more quickly, so we should probably use higher doses, more frequent boosters, things like that. But overall, definitely the concept that some protection is better than none should be something that you really refer back to again and again. We had guidelines that recently came out in clinical transplantation, and this is from the American Society of Transplantation, where we do have recommendations for routine vaccines for adults and children. You can see the contraindicated vaccines are the same as in the CDC guidelines. And then we also have travel-related vaccines that are recommended for adults and children, and then which ones are contraindicated as shown at the bottom of the slide. I will talk in more detail about this, but just to highlight that we do have guidelines that were published in Clinical Transplantation last year in case you're interested in reading further details on this topic. Now I'm going to skim over some live viral vaccines. So in Brazil, I know that you're quite familiar with yellow fever and the yellow fever zones, which obviously affect much of Brazil, but also many other places in the world. And when possible, we recommend that people avoid being in those areas. Although obviously in Brazil, plenty of people live in those areas. So we would consider a pre-transplant vaccine whenever possible. And I'll show you some data on durability of that vaccine response. What we're trying to do is vaccinate them before they are immunocompromised so as to avoid disease from the yellow fever vaccine, which is called yellow fever vaccine-associated viscerotropic disease, which is fatal in about 60% of cases and really can be quite devastating. This is a nice case report with disseminated viral infection, and you can see the yellow fever virus antigens here in red, and it affects much of the system and really can cause quite devastating illness. So in the CDC guidance, what did we say? We really recommended that people, whenever possible, be discouraged from going to destinations that present a true risk for yellow fever. We do recommend that they avoid yellow fever vaccine. And if it can't be avoided, they should be informed as to how to avoid risk. And they should bring a vaccine medical waiver. However, certainly, and I've discussed this a lot with various Brazilian infectious disease and other transplant specialists, the risk benefit for somebody living there is likely to be really different than for a brief traveler from abroad. And so that is really food for thought. But again, whenever possible, best to try and vaccinate people prior to undergoing immunosuppression. That would certainly be the safest approach. And there have been some really nice papers, many of them from Brazil, looking at various immunocompromised populations. And basically, they were able to vaccinate a variety of rheumatology, organ transplant, HIV patients without adverse event. I don't know that that means that we should apply this to everyone traveling to yellow fever regions, but in Brazil, the risk-benefit equation may be that you do actually want to vaccinate patients. If you decide that they can't get the vaccine, really important to give them this medical contraindication to vaccination so that they are allowed to cross international borders. Otherwise, they could be stopped, and it could be enforced that they undergo vaccination. This is the only vaccine that is mandated for crossing some international borders. If they are being forced to undergo vaccination, you may wish to educate them and just tell them that they really should not get the vaccine at any cost. So there was work done by this group in Paris that is really excellent in that I think it provides all of us a lot of comfort. They looked at 53 organ transplant patients who had undergone yellow fever vaccination prior to organ transplant, and they looked at their titers of antibodies, a median of 3 years after transplant, and all but one of them had protected antibodies. And so it does look as though pre-transplant vaccination works, and you don't necessarily have to give boosters. And hopefully this provides a lot of comfort, especially to Brazilian clinicians who are wondering, are their patients at risk for developing yellow fever? What about measles? Well, there's a lot of measles through much of the world, and optimally, people should be vaccinated prior to undergoing organ transplant. Hopefully, most of your patients are already vaccinated or protected from natural disease. You could consider with travel giving them things like gamma globulin or IVIG, but I would caution against giving the live viral measles vaccine for travel because they could develop encephalitis. I've actually had some patients cancel travel to measles endemic area when they heard about the risk. So it's an important topic to discuss because it's so common. What about Japanese encephalitis? Here are the risk areas. Usually we only give vaccine if they're traveling to a very risky area for usually a month or longer. So it's not something we give so commonly. There are several vaccines available. The ones that we have available in the United States are inactivated, so would be safe. However, there are live attenuated vaccines that are being given. I wasn't entirely sure what is being given in Brazil, but I would make sure that you're not giving live viral vaccine because that actually could be dangerous. There really isn't data on the use of these vaccines in organ transplant recipients, but again, if it's not a live viral vaccine, then it's probably reasonably safe to consider giving it to organ transplant recipients, or you have to at least think about the risk and benefit depending on the type of travel duration and all of that. I will say that there's interesting data on poliovirus. So we use the injectable polio vaccine, and so there's not a risk of it converting back to wild type, but we do see that with oral polio vaccine. And this is an interesting case report of a mother who had common variable immunodeficiency who was exposed to her child who had the oral polio vaccine, and it was in her intestine replicating for 12 years and finally reverted back to wild type, and she succumbed to polio, which is fairly dramatic, but food for thought. And it is recommended that people who are traveling be aware of the risk of transmission of oral polio vaccine by the fecal oral route in parts of the world where that vaccine is still given. So food for thought. Again, the injectable polio vaccine is fine, but this would be risky, especially if they were exposed through food and water or the fecal oral route. For people not protected against varicella or what we call chickenpox, optimally they would have been vaccinated prior to transplant, and it would be very challenging to give them this vaccine after transplant. You may wish to give them acyclovir if you are concerned about them being exposed when traveling. We have a varicella immunoglobulin, but that's actually very hard for us to obtain and quite expensive, and that's a challenge. If they are on very low dose immunosuppression, I guess you could consider vaccinating them in that we do have acyclovir for treatment, so I feel a little more comfortable at this vaccine compared with the MMR vaccine, the measles vaccine. What about cholera? So there is a live bacterial vaccine that was approved in 2016. There's unfortunately no data in immunocompromised patients. There are 3 other inactivated non-live cholera vaccines available as listed here. In general, they're not that immunogenic, and we only recommend these for patients who are truly going to very high risk situations, often healthcare workers in cholera outbreak situations. There's this paper by Dr. Visser's group where they looked at the oral cholera vaccine Dukoral, and overall it looked reasonably immunogenic and reasonably safe. So there is some data on this vaccine where more than half of the transplant recipients seroconverted. So it's reasonable to consider giving it. I have to say I've never given cholera vaccine to a transplant recipient, and I do see a lot of them. Most transplant patients aren't going to cholera risk areas. There's also typhoid fever. So typhoid fever exists through much of the world. There are 2 vaccines on the market. One is the injectable vaccine, which generally gives 2 years of protection, and that's the one we would prefer because it's not a live vaccine. There's also a live oral vaccine called TY21A. That's the name of the strain. In general, this is contraindicated for immunocompromised patients. It does give 5 years of protection. In general, I would tend to favor the first one, the injectable one, and just likely give booster updates as needed. But again, paucity of data, really no data on the use of these vaccines in organ transplant recipients. Now a couple of comments on non-live vaccines. The first would be hepatitis A. So it's interesting, hepatitis A is one of the vaccines we commonly give for travel medicine. In Brazil, you probably have more people who are hepatitis A seropositive at baseline, which is great, so you don't have to worry too much about that. We do try hard to vaccinate people prior to certainly liver transplant, but also other organ transplants in the United States, especially if they plan on traveling after transplant, because vaccine works much better prior to transplant. You can see in looking at a mixed population of patients on immunosuppression, stem cell transplant recipients, HIV positive, etc. After 1 to 2 hepatitis A vaccines, about 3/4 of them developed a positive antibody. And if we look further at the details, unfortunately, this is a combination as shown in the red boxes, liver and or kidney transplant recipients. And what this shows is after a single dose, there's a very low rate of seroconversion across multiple different groups. You know, the second line down is 41% of the liver transplant and 24% of the kidney transplant seroconverted after a single dose. But those numbers are greatly augmented through a second dose. So if possible, worth giving them 2 doses, but you may not have enough time. I mean, often I see people and they say, like, I'm getting on the plane in a week. So it's really hard to get this done. But do be aware that overall, there's a very low rate of seroconversion with 1 dose of vaccine. In this population, it was 37%, bumped up to 82% with a second dose. There's an interesting study in rheumatoid arthritis patients, I don't know of similar data in organ transplant recipients, but where they gave a double dose of hepatitis A vaccine, and that was shown to be more likely to result in seroconversion. So that's something worth thinking about if you really are concerned about somebody and their hepatitis A risk, but they're traveling quite soon, so you don't have time to get 2 full doses in. So worth thinking about. In general, for hepatitis A, really important to think about vaccinating prior to immunosuppression, think about double dose vaccine, think about boosters. In the United States, we have something called Twinrix, which is a combination hepatitis A and hepatitis B vaccine, but honestly, it doesn't give hepatitis B protection in this population, so I really don't recommend it. When people are traveling to a high-risk area, I sometimes think about gamma globulin, but usually we have to give quite high dose based on the new guidelines. So in general, I'm not a big fan of that for travel. I try really hard to go with vaccine whenever possible. And then I would just have a low threshold to give booster doses with subsequent travel, or if you're concerned about waning immunity. What about hepatitis B vaccine? So this would be recommended for people who are traveling to countries with high or intermediate endemic hepatitis B. There are a variety of vaccines that could be given. It is hard to get them to seroconvert after organ transplant. You may wish to use high-dose regular hepatitis B vaccine, or we have something called Heplisov, which is an adjuvanted hepatitis B vaccine. And either of those approaches might be more likely to result in seroconversion. We usually try to get people vaccinated before transplant because of the risk of hepatitis B exposure at the time of transplant. Rabies vaccine should be a non-live vaccine, at least in the United States. It is there are some live viral vaccines out there, so be very cautious about that because you could potentially give someone rabies through vaccination, which would be bad. So we definitely recommend these inactivated vaccines. For high-risk situations, you may wish to consider giving them this vaccine prior to travel so that they're better protected, especially because they are less likely to have a good response after undergoing, say, a dog bite and getting vaccine at that point. It's worthwhile knowing that especially with rabies vaccines, but also Japanese encephalitis and other vaccines, that there are counterfeit vaccines out there as well as counterfeit immunoglobulin. And there have been disease transmissions from these vaccines, which is really unfortunate. So worthwhile having that conversation with your patients. Influenza vaccine, like the Nike ad says, just do it. So remember that flu circulates in the southern, sorry, I should have switched this to northern hemisphere, the other half of the year. So when you don't have flu, we do. So worth vaccinating people who are undergoing travel. And you may need to give booster doses or higher doses of vaccine. Dipali Kumar's done some beautiful work in recent years on those topics. And then think about also, if you're really worried that they're going into a high-risk influenza region, you may wish to give them a treatment course of oseltamivir. And I just wanted to highlight, there are a variety of coronaviruses underway. So far, we don't have anything that we're giving in real time, but hopefully this will be part of the vaccine equation for travel medicine at some point in the near future. Preparing for travel includes more than vaccines. There's a lot to talk about educationally. I think insurance coverage for medications, preparing and bringing extra medications in case of travel delays is really important. You definitely don't want people to start taking medications that they got in a different country. They're usually so expensive, it would be hard for them to obtain. So I do encourage people to have as many medications plus extra when they're traveling. Make sure that they're in the original containers. They should make sure that they bring a list with them so that they have the details of their medications. Think about crossing international borders. Make sure that the customs officials are going to be comfortable with the packaging and that it's going to look like real medications and that they won't be confiscated. Consider that they should also be prepared for prolonged lack of refrigeration. And discuss with them that they should avoid taking medications that are purchased at various destinations. They are at risk for counterfeit medications. You know, there are many of them throughout the world, and that can be a real problem. And then talk to them about the risk of drug-drug interactions and QT prolongation and those things, so that they don't just take medications that could have severe adverse events. Also, that would be a good time, you know, if they're going to start a new medication, maybe they should get in touch with you or your transplant program and just discuss the risk. Antibiotics for self-treatment. We do think that this is an important component of travel medicine, especially for the immunocompromised host. So in general, I look at their prior infection history. You know, have they had recurrent urine infections, recurrent skin and soft tissue infections? Do they have allergies? Do they have resistance to antibiotics? And then I will often give them 1 or 2 antibiotics depending on the duration of travel and the risk. They should also be potentially able to treat things like malaria and influenza, but that depends on the nature of the travel. It's very rare that I give people self-treatment of malaria or even influenza, but if they're going to be somewhere for a long time. And then think about where they're going to and what infections they're at risk for. I often think this is a time to be generous and just give them careful instructions as to how to use, but this is, I don't usually, I tend to give them a fair number of medications for self-treatment. If you're giving malaria chemoprophylaxis, do think about drug-drug interactions, whether they need dose reduction, either malaria medicines, travel diarrhea treatment, altitude sickness prophylaxis, and thoughts about whether this needs to be changed based on their kidney function or liver function. So we included this in the guidelines. And then also think about drug-drug interactions and what the impact overall might be. And so there's some really key things to educate them about. Think about what to do if they get sick in country. Think about blood product safety. Think about higher risk of multi-drug resistant organisms, and they should be very clear if they're sick after travel, where they've traveled and what they might have been at risk for. They should be super careful about sun protection. They are at more risk of sun exposure when traveling, and as we know, they get much higher rates of skin cancer. Think about things like mosquito and tick precautions and clean swimming and discuss that with them. Also, as always, vigilant food and water precautions, and think about alcohol-based hand sanitizers and hand wipes, etc. And then consider bringing a first aid kit. I think what we're trying to do is avoid things like this balamuthria from a therapeutic mud bath in Jamaica, right? None of us want to be seeing that in clinic. In the guidelines, we have recommendations for what to put in a first aid kit, just as shown here, and that can be really helpful for patients to think about. And so just in summary, here are some useful resources for travel medicine. Again, the guidelines, the CDC Yellow Book. We also have a chapter in Up to Date. There are some really nice Australian guidelines as well. And there's sort of been a variety of things published on this topic. So just in conclusion, think hard about the net state of immunosuppression and optimal timing of travel. Think about pre-transplant vaccines and doing those as much as possible. I usually, when I'm seeing people prior to transplant, I do ask them about travel, and sometimes I give them yellow fever vaccine or other vaccines because we know that they're going to travel to an endemic region after transplant. Avoid live vaccines after solid organ transplant. Use non-live vaccines, perhaps more frequently, to boost their immunity. And just think about also protecting the immunocompromised patient by surrounding them with well-vaccinated family members and colleagues. So they're not the only ones that should be coming to travel clinic, they should bring their family as well. And just discuss, educate, and plan. And for the most part, I've had a really good experience sending people on wonderful trips. They are thrilled to be able to travel after transplant. And I think if we do it safely and cautiously, we can overall have some really good outcomes. I'm happy to have questions either now or in the future, and that's my email address as well as the hospital where I work. Thanks a lot for your attention.
Hi, Dr. Kotton.
Hello.
Hi, how are you?
Nice to see you.
Oh, it was a great pleasure and an excellent talk. It was a great review of medical travel medicine that is not our usual field of interest, and it was very interesting to know about the protocols. And we still have 2 questions. Is it okay?
Sure.
So,
sure.
The first one is about the Hep A vaccine. Here in Brazil, we have a protocol that we use just one single dose, and generally for general populations, not specific for post-transplant patients. And I saw one of your studies, that your presentation, about the lack of immunity due to just one dose. Is it just for post-transplant patients? Is it for everyone? Could you talk about it?
Yeah, that's a great question. Usually hepatitis A vaccine works pretty well, and we think that one dose of vaccine, at least what we're giving in the United States, gives at least 1 to 2 years of protection, so that's adequate for all travelers.
Mm-hmm.
However, for transplant patients, there really is a decreased response to vaccination. So that's where we would recommend either 2 doses separately, or if it's possible to do 2 doses at once, that might give a better level of protection. I guess I would especially recommend that for those transplant patients who are on higher doses of immune suppression. It's actually pretty hard to give good protection against hepatitis A, as I showed in those papers. So yeah, these are things I struggle with. In the United States system, they don't really want to pay for 2 doses of vaccine, so it's actually a little harder to do.
Okay, great. And another question is about yellow fever. Last year in Brazil, we had some cases of post-vaccinal disease due to yellow fever. We have some number of cases that increase in the middle of the year, and we have some post-transplant patients who suffer from this kind of complications, vaccinal complication. What about your recommendation for this group of patients, post-transplant patients that goes to these areas now with prevalent yellow fever case?
Right. So in Brazil, this is a really different equation. In the United States, it's mostly people who are traveling, and I can convince them to go to a non-yellow fever area. But obviously in Brazil, they may be, maybe it's work or family or whatever. I think whenever possible, it would be great to give them the yellow fever vaccine in advance of transplant. And I thought that data from Paris was so exciting because all but one of the patients had long-term immunity from yellow fever vaccine. So I thought that was really good and exciting and really helpful. And then there are various papers from Brazil where weighing the risks and benefits, if somebody is from a yellow fever endemic area and has undergone transplant, but you're really worried about them getting yellow fever, then, it may be worthwhile vaccinating them. I guess I just worry, it depends on what their real risk is and whether it's worth it or not. And if it's not worth it, that's usually what we would decide. But then if you think it's worth it, then you may wish to give the vaccine. But that's one of those really careful decisions that you'd want to make with the patient, understanding that there is some risk that they could have something awful from the vaccine.
Perfect. Yeah.
Mm.
Perfect. Is there any questions? Okay, so Dr. Kotton, thank you so much. It was a great pleasure.
Thank you for inviting me. And I'd like to say thank you to Francisco for helping me as well. He was great.
No worries. It was a pleasure.
Thanks.
Okay, so if there is no question,